One of the emerging themes from this meeting has been MRD, what we used to call minimal residual disease. There's some shift in terminology. Now it's emphasis more on measurable residual disease, and also a shift away from label simplistically as negative or positive, now more clearly specifying what the threshold of testing. The most informative threshold that we have, and tools like flow cytometry are able to readily achieve, is 10 to the minus 4, or 1 cell in 10,000, so-called now MRD4. Achievement of that level, we've shown with previous chemoimmunotherapy, very clearly stratifies for outcome after cessation of treatment. MRD has now been accepted both in Europe and in the United States as a useful measure comparing trials and comparing regimens. So, for example, venetoclax rituximab can achieve an MRD negativity rate in the marrow of about 59%, in the blood of about 80%, comparing to single agent venetoclax where it's about half of those figures. So it allows us to compare, is this regimen more promising than that regimen? But we're now shifting to the point where it's informative for the individual patient. And the Murano data that will be presented at ASH this year will inform how it identifies the expectation of outcome for an individual patient at the point of stopping treatment. So Murano stopped treatment after 24 months in all patients, and we have MRD information that will allow us, we hope, to then stratify what the expectation of how long your disease control may be after cessation based on what your depth of remission is. That will then allow us to better target what the MRD depth is, what are we aiming for, to then enable treatment cessation, hopefully, ultimately in all patients. So we've moved from a research tool to an approved indication for comparing particular trials. Now we're moving into using that to inform individual patient treatment choices.